The topic is to talk about the PRGF endoret. For many people, what is PRGF endoret? Is the endogenous regenerative technology. The PRGF endoret is the first reported 100% autologous and safe plasma-rich platelet described in scientific publications. It has a concentration of platelets for a small volume of blood. I had the idea to substitute the clot of blood with a clot from which I removed all the cells that were in the blood that didn't have any role in tissue regeneration. And importantly, I concentrate all the platelets that have an important role, but in one specific concentration. It's very important to use in one specific dosage, like all the antibiotics, like all the medicaments. I call this technique PRGF endoret. We start, observe, study, and analyze the blood. The blood go across that all the tissue and have a very important role in tissue engineering, contain proteins, and always are in the beginning of all the process of regenerative tissues. This is the blood under electron microscope. The blood is the responsible of the regeneration of all the tissue in the body. In the last 20 years, we have studied the biological and hemostatic properties and the blood clot, and we have tried to develop a technology that improves its physical properties and its regenerative potential. In this picture, we can observe the differences between a blood clot and the PRGF clot. Observe that the net are completely different. In this perfect net that we can obtain the PRGF endoret, because I remove all the cells that interfere in this net. Tissue engineering consists of working with cells, proteins, and a scaffold. The PRGF is probably the best scaffold that we can use, and at the same time contains proteins, sorry. The only thing that we need is to place cells. This is the clot, the white clot that we use that are really different with the standard clot of PRP. This technique has changed the course of many different treatments in many areas of the medicine. We take a small volume of blood, we centrifuge it, and we obtain the PRGF in two different layers with different concentrations of platelets for different applications. With this plasma, we can obtain even different biological products, of course, with different medical applications. Which are the differences between the PRP and PRGF endoret? This was one of the questions of the course of yesterday. If we observe the historical perspective, in 70, Matras started to use one PRP. Taya-Ponsac in 94 stand also to try to obtain one autologous PRP. Whitman and Marx continue in this direction. All of these authors aim to obtain an autologous fibrin adhesive, but they did not succeed. They need bovine thrombin to activate the platelet-rich plasma, and they need a large blood volume to elaborate the PRP. The PRG endoret is 100% autologous, is one evolution of the PRP that will be possible to prepare with a very small volume of blood, even only 10 cc. Since then, I published over 100 papers internationally about the characterization and different application of the PRGF in different tissues. We have developed 4 different therapeutic formulations: liquid, plasma-activated, clots that can contain cells, biomaterials, and fibrin scaffold. We study the bacteriostatic potential of the PRGF endoret, and we evaluate the bacteriostatic potential against Staphylococcus aureus and epidermis and all the difference. We observe with different concentrations of PRGF the different effects, the different bacteriostatic effects. Note the differences in the fibrin structure, depending on the type of diffraction that we evaluate. We can observe in this picture blood, PRGF with two different fractions, and PRGF with leukocyte. In other words, one PRP that normally even contain red cells. And we study the bacteriostatic effect and are exactly the same. We observe that include the white cells don't change at all the bacteriostatic effect, but interfere with many cytokine, many metalloproteases, and many inflammatory interleukin. Let me show you how the PRGF works. On one hand, we can obtain proteins that are in the plasma and in the platelets. We can activate it, and we can control the kinetic of the release of these growth factors to liberate when we want it. On the other hand, we obtain a fibrin scaffold, a greater scaffold. Now, I'm going to show you the effect and the laboratory condition of PRGF in cells. The mitosis is marked with red circles. In this experiment, we can compare, and the control condition, the effect of the PRGF, and we compare with the control, with one standard medium. In this video, we can observe the comparative rate of division in the cells. In just 48 hours, you can see that we obtain 3 to 4 times amount of cells. And after the body, the intracellular pH, and also the concentration of oxygen equilibrate this proliferation. In this other experiment, we have cells, in this particular case are osteoblasts, and we create like a river, one gap, one space between the cells. And again, I wanted to observe the effect of the PRGF compared with the control. We observe the different movement and the different chemotaxis of the cells. In the same experiment, but with a different family of cells, in this case with fibroblasts, we observe the spectacular movement of the epithelial cells. For this reason, we can obtain a very fast healing. Here, in this video, we can see, with increasing magnification, the quality of the scaffold that we can obtain with the PRGF endoret. We can use a little as 10 cc of blood to obtain this clot. We observe with electron microscope that we increase the magnification, and we observe the perfect net that we can obtain with the PRGF. The most important thing is that this net is like one sponge that contains proteins, autologous proteins of the patient. We analyze the proteomic effect of the fibrin even after hours that liberate all the proteins, and we observe that contain near the 100 proteins even after 10 hours or 12 hours. In other words, the fibrin scaffold continue the liberation during days, all of these growth factors. This is the perfect net that we can obtain with the PRGF that can contain also cells if we want to place cells. Now, in this video, we can see that it's impossible to manipulate the blood. The blood is really a very poor scaffold. If we compare with the fibrin that we obtain with the PRGF, we observe completely different consistency. Even it's possible to suture. In other words, will be possible to prepare probably the best scaffold, even probably one of the best biological membranes that we can use in all our surgery, like biological barrier. To obtain a good sealing around our implant. For instance, in this case, for immediate loading. The first application of this technique was a routine clinical situation. a post-extraction defect. We fill up the defect with a clot of the pure GF and with a very dense fibrin that we obtain also with the pure GF endorette. Observe this big defect. When I clean this type of the defect, I usually end with an oroantral communication that always are very complicated and very unpredictable, obtain the healing. In this series of images, we can see the evolution of the fibrin, even in contact with the saliva, in contact with the bacteria. If we use this fibrin scaffold, you don't need to close the flap in post-extraction socket. And we observe that you can stimulate, you can obtain, you can regenerate the connective tissue that we observe in this example. On the other hand, after 3 or 4 months, we observe that we regenerate completely the bone defect that we can analyze with the scanner, and we observe a great density to place implants. This is follow-up X-ray after 10 years. Other cases, post-extraction defect, immediate placement with a big defect. Which is the best approach? Which is the most predictable approach to close this defect? The blood graft is one alternative, but it's possible other less invasive technique only using the bone that we recover drilling in a clot of the pure GF covered with fibrin. We can observe that will be possible to obtain first good healing without primary closure. We observe that the fibrin in few days, only in 1 week, we healing completely. After 3 to 4 months, we reopen the flap and we observe the complete regeneration of the defect, just using the bone that I recovered drilling and the pure GF and the fibrin that we obtain with the same technique. These are the X-ray, these are the final result, and this after 12 years. We observe that the results are still stable. These are a clinical trial, double-blind, randomized study, the same patient, the same sergeant, similar defect. One defect I fill with the pure GF endorette, the other just with blood. Both I suture to obtain a good stability of the clot, and everybody can observe the differences. In just 5 days, we observe completely different healing. The conclusion, the treatment is safe, no side effect reported, promote faster soft tissue epithelialization, swelling and pain reduce, stimulate the bone tissue regeneration, less complications, and probably one of the most important things, never we find a dry socket. We study also the density of the bone in the defect, and we observe that we increase the density 180% in the alveolus. These are our experience, these are our study, but today there are many other authors around the world that obtain similar results, that publish also similar results. Also, we use this protocol in orthodontic surgery, in fractures, not only in oral maxillofacial surgery, also in orthopedic. Other applications, we can wet the surface of the implant to obtain one biological interface. What happens? If you use saline solution to irrigate the implant, or if you don't use nothing, the surface of the implant have many bubbles of air. If you wet the implant surface, you obtain one biological interface. In this animal study that I published a few years ago, we observed that we increased the 85% the bone implant contact. These are other studies in SIP models that we observe how we can stimulate the bone apposition. We can obtain apical growth in the implants, and we observe that we increase the bone implant contact drastically. In other words, we can obtain one predictable biological interface. Compromised cases like this fracture, horizontal fracture, is a case in the aesthetic zone, always with a very compromised situation. I must do the extraction, the two fraction of the tooth, and when you place the implant, we have a big gap, 3 millimeters of the gap, which are the most predictable approach to obtain a good regeneration of this tissue. There are many different techniques, many different biomaterial, but why not offer one opportunity of the biology? Observe this video. This was the defect. The patient have a fistula. Of course, I cleaned very well the defect. What is this? This is the bone that I recovered drilling this alveolus. A very slow speed, only 100 revolutions without irrigation. I prepared a clot with a fraction 2 of the pure GF. We can condense the bone in the best biological situations, in the best medium, like I showed you before, and I condense the bone. But what is possible to do now to sealing this big defect? These are a clot. These are the fibrin scaffold that we prepare with the other fraction of the pure GF. You can condense the fibrin and you can seal completely the defect. These are the situation. And in only 4 days, we observe the healing. Is magic? No, it's exactly like I saw you in the video. The fibroblasts go very fast, and we obtain a very fast healing. In only 4 days, during this time, the patient used one removable prosthesis. I prepare the final abandonment in the lab, and I prepare the provisional. And the patient, in 4 days, have fixed teeth. Observe the stability of the result, and after 4 months, the soft tissue maintained stable. And after 4 months, we prepare the final crown, and everybody can observe the stability of the soft tissue and the stability of the bone around implants. I can show you many cases like this because this is the standard treatment that I am using in my practice the last 15 years. All the similar case, similar gap, we fill with pure GF, 5 days, good healing. I prepare the final abandonment in the lab, provisional. After this time, I remove the provisional, I keep the abandonment, we prepare the final crowns, and after 3 years, we observe a good stability of the soft tissue around the implant. These are the situations before and after. There are other cases with a vertical fracture, with a big defect. The patient loses completely the buccal wall, has suppuration, is not really predictable with so big defect to place the implant in only one stage. Which is our approach? To fill the defect with a clot of pure GF, with a fibrin scaffold, suture in only 8 weeks or 10 weeks will be possible to place an implant. I regenerate the 100% of the defect. If I wait 4 months, yes, but in 10 weeks will be possible to place an implant. The bone is hot at this moment, are in the great situation to overcorrect with the graft, with the bone that you recover just drilling, and these are the final result. Only using the biology, only use 100% autologous products, the blood of the patient and the bone of the patient. These are one very predictable technique. This technique I use also in the very narrow crest. When I do a split, what is the best product to fill this defect? Just you fill with the pure GF activated, I overcorrect, and these are the result, are a very predictable result. What is the most reliable approach to treat the periimplantitis? Which are your protocol when you receive one patient like this? All the dentists do 1, 2, 3 different surgery, and the patient continue with pain with suppuration. In this video, that also will be possible to see in Dental XP, what is our approach? I open the flap to observe the defect, to clean very well the defect. And we use this new specific instrument to remove the implant just to contra-torque. I fix the structure and just 150 Newton contra-torque, I can remove the implant the very atraumatic way. Now is the time to clean perfectly the defect. And which is our approach to regenerate this defect? Remember, this area are contaminated. The PRGF have bacteriostatic properties. For this reason, I clean very, very well the defect. Many times I use antibiotic to clean, to be sure that all the defects are perfect clean, and I fill with a clot of PRGF. Clean with the antibiotic and fill with a clot and fibrin, and that's all. We observe with electron microscope always that I remove one implant. I analyze how are the surface. When you observe with electron microscope how are the surface, and also with the XPAs, you observe the contamination of the surface, you know that that's really unpredictable to clean one implant in the mouth. In my hands, it's completely impossible to regenerate the bone the one predictable way around the implants. For this reason, my approach is to remove the implant, to fill the defect, and observe that I regenerate the 100% of the defect only using the autologous proteins of the patient. And after 4 months, you can place a new implant. It's possible to reverse the osseointegration. 10 years ago, I asked myself this question, and I developed this technique to remove today the 100% of the implant that have periimplantitis in my practice. I do many research in animals to analyze different techniques and observe the quality of the bone when I recover, when I remove the implant. And we observe that with this technique, from one histological point of view and from one biological point of view, the bone are in great situation even to place a new implant. These are the explantation kit with different tips to adapt a different connection. And the method of use is very easy. You choose the corresponding extractor, you place in the connection, and with the racket of the contra-torque, you observe that you can fix in different connection. And with this contra-torque wrench, you can control the contra-torque. Why? If you do too much contra-torque, more than 200 newtons, you can break the structure, you can break the implant, or you can break the bone. For this reason, if I want to remove one implant, only the 5% of the implant, you need to use this technique. You can use one specific trephine, only 2 millimeters, maximum 3 millimeters. Why? Because we know with finite elements, with one implant out of osseointegrate, only work the first threads of the implants. With this trephine, we observe with thermography that don't increase the temperature, even will be possible to use without irrigation. And you drill just around the implant 2 millimeters with a very thin trephine. And you can remove, with this technique, the 100% of the implants. But observe what happened. This was one implant that was impossible to remove at more than 200 newtons. When I introduced the trephine, I removed the implant at less than 100 newton of the contra-torque. But the most important thing is that all the bone keep in the alveolus. you fill with pure GF, and in just 8 weeks, you can place a new implant. Every week, I receive patients in this situation. Which is my approach to treat this patient? One connective tissue graft. Always, my approach is to remove the implant. This video is just 1 minute. You place the extractor, contra-torque, and you remove the implant in just 10 seconds. The very atraumatic way, and the very, very easy way. You remove the first implant, you remove exactly the same, the second implant, you clean the defect. These are the implants, and only with one surgery, the 5 minutes, you are in one situation totally different. And now is the time to regenerate and to finish with the final prosthesis. We report positive results using the pure GF Indorette in orthopedic surgery and sport medicines the last 10 years. This was the first case of a diabetic lady, 78 years old, with a large necrosis in his knee. And in 7 weeks, we completely changed the evolution of the case that would probably end in amputation. Probably everybody knows this guy that have a severe problem in his tendon. I was treating 3 years ago, and even this year again with a big problem that have in his tendon. We treat hundreds of athletes in Spain and around the world with this technology. In this direction, we start to use also in dermatologists. I do many research that I publish in the most important magazine, Journal Biomaterial Research, Plastic Reconstructive Surgery, and we analyze in the lab and in clinical trials the effect of the pure GF Indorette in the skin. Observe this case. This was a curious case. I placed implants in this patient, and he explained to me that he had to cancel his appointment for the final prosthesis because he required an important surgery on burns on the lower back. He showed me the defect, and the pictures speak for themselves. I infiltrate the pure GF, I place the pure GF, and everybody can observe the evolution. I place the pure GF every week. I show you the pictures every 2 weeks for Go Faster, and everybody can observe that it's possible to regenerate the skin. Like I showed you that it's possible to regenerate the connective tissue. And we observe the change is dramatic. Over the last few years, we have been treating wrinkles in atrophic cases and also for anti-aging and aesthetic treatments. I do a clinical trial to study the efficacy and safety of the pure GF in skin regeneration. We analyze the skin biotypes, and we treat against the hyaluronic acid. And we observe that the pure GF obtains much better benefits than the hyaluronic acid. But probably the most important thing is that after 6 months, all the patients treated with hyaluronic come back to the same levels, and all the patients with pure GF maintain in a good levels. Normally, this is the time to infiltrate again. If we observe many other different data, like pH, we observe on the sebometry a very significant result. The result, more significant, are the hydration and the reduce drastically the wrinkles. And the technique is very simple, like everybody can observe in this video. With the pure GF activate, you can infiltrate the wrinkles. It's not a filler. Are proteins of the patient. You won't stimulate the dermis and the expression of the hyaluronic for the patient. You can treat normally every 2 weeks, 3 or 4 times, depending the type of the patient. And I think that is probably the best way to finish one big treatment in severe resorption. These are the result. In many cases, are spectacular. We publish many articles, many books that everybody can read. Many of them are in dental XP, and I like it always to introduce the new technique based in science. Thank you very much for your attention, and see you in our institute in Vitoria. Thank you.